Good evening, everybody. Thank you so much for joining me tonight on YouTube Live. I'm Dr. Howard Elkin, the medical advocate, and tonight we're going to focus on diabetes. After all, November is National Diabetes Month. And some of you may be saying to yourself, well, diabetes, that doesn't really apply to me. What do I need to learn about it? And I'm here to tell you that this is a very important disorder, and it affects so many of us. For example, did you know that in this country alone, there are 35 million people with diabetes? That's over 10% of the adult population in this country. And actually, about 21% of these people are undiagnosed. They don't even know they have it, which is why this is so important. And then, if you look in the if you look ahead, by the year 2050, they expect this number to go to 55 million. That's like a 50% increase. So, diabetes is rampant, and you have to remember that doesn't include pre-diabetics. If you look at pre-diabetics, there's 88 million people out there that have pre-diabetes. And here's why it's so important for you being a medical advocate is that medical advocates look beyond the standard testing. We want to know everything we can about how to prevent a problem. And the problem, as I see it, is that most doctors are not ordering the appropriate test to rule out diabetes, or more importantly, pre-diabetes. So we're going to talk about that tonight. But the magnitude of this disorder is incredible, and it doesn't seem to be disappearing anytime soon. Now, you also probably have heard me say in the past about insulin, about metabolic syndrome, and this is a cluster of five factors. One is, excuse me, hypertension, high blood pressure, high blood sugar, low HDL or healthy cholesterol, also increased waist circumference, and I think it's a bit, and triglycerides. Right, I mentioned that. There are five. If you have three out of those five, you constitute what's called metabolic syndrome. So why do we even care? Because metabolic syndrome, the hallmark is insulin resistance. Your body doesn't recognize your own insulin or doesn't utilize it adequately. So what happens, the body keeps on making more insulin, and insulin is really damaging to the heart muscle, and it's also damaging to the brain. So hyperinsulinemia is not good. Metabolic syndrome is not good. And again, 88, if you remember from my previous talk here, 88% of the adult American population is metabolically unhealthy. That's right. Only 12% of us are in the metabolically healthy category. I mean, that's terrible. That really is terrible. So this is very important to talk about during Diabetes Month, because we're not talking just about diabetes. We're talking about metabolic syndrome, prediabetes, and most important, how to detect this at an early stage so we can do something about it. Okay, now, folks, make no mistake about it. This is a bad disease. There's nothing good about diabetes. Okay, as a cardiologist, I have to be intimately interested in this. 70% of diabetics will have a heart attack or a stroke in their lifetime. That's huge, right? So it's so important. And so many people have coexisting heart disease that when I have a diabetic, I have to look at their cholesterol and their lipids as if they already have a heart disease, if they already have had a heart attack, even if they don't. So I treat them as aggressively as I would a patient that's had a heart attack or a stent, because again, it's not in their favor. Also, kidney disease, end-stage kidney disease. Anywhere from 10 to 40% of diabetics, and this really depends on what your source is, 10 to 40% will end up on dialysis with end-stage renal disease. Not a good way to end your life. Also, there's nerve damage, painful neuropathy. There's damage to the brain, to the nerves of the feet, and it's described as people describe it as like walking on pebbles. It's just not comfortable. GI motility is affected. A lot of people develop what's called gastroparesis. They can't adequately digest their food, so it just hangs up here in the stomach, and they digest very slowly, and it's not a healthy way to go. So, and one more thing, blindness. There's also a fair amount of disease. Blindness associated with diabetes. Again, not a good disease, but here's a couple of things that you might not be as aware of, and that's cancer. There is definitely an association of diabetes with cancer. It was thought, well, now cancer a risk factor for diabetes? Is diabetes a risk factor for, this debate has gone on and on, but it's been shown recently that there clearly is an increase in cancer, in all kinds of cancer, in those that have diabetes. And it's also, there's a genetic difference. For example, women are 27% more likely to develop 20% more likely to develop cancer. That means diabetic women versus 90% men. So we don't know really why women live longer, but we really don't know why that's true. But there's definitely a genetic difference between who develops cancer or not. So 27% in women, 19% in men. There's a difference. And so the reason we think that this is such an important thing is that this is important. Insulin and hyperinsulinemia, when there's too much insulin, leads to growth. Now it leads to, and I remember in the bodybuilding days, I used to compete in bodybuilding. A lot of bodybuilders, especially pro bodies, would take insulin because it would help. It's anabolic hormone, helps to build muscle. It also helps to store fat, and it also helps to promote tumor growth. So insulin is not our friend when it comes to trying to prevent cancer. So that's an important thing to keep in mind. The other one is Alzheimer's disease and dementia. We've known for years that diabetes can affect the small vessels of the brain and cause dementia, but really there's a big, big interest now in its effect on Alzheimer's disease. And we know that Alzheimer's disease also, that hyperinsulinemia, or too much insulin, can lead to damage to the brain. So it's kind of important in fact, there's a 1.5 to 2.5 increase in Alzheimer's in those with diabetes. So it's not a good disease. And now it's something that we all need to know about. And now I want to talk about knowing your risk, because as medical advocates, we all want to know, what is our risk? I don't care how low or how high your lab value is. I want to know, what is your risk? So we look at a test called Hemoglobin A1c. Your fasting blood sugar means nothing to me. It could be 100 one day, it could be 90 the next, it could be 110 the next. I tell patients that that's only what your blood sugar registers at the moment your blood was drawn. It really is not terribly useful value for looking at the total picture. So we look at something called Hemoglobin A1c, which is a marker on the red blood cell. Now, you might know that red blood cells last 90 days, 3 months. So it gives us an indication of how well your diabetes has been controlled, your blood sugar has been controlled for the previous 3 months. So it's a really useful value. So we like it to be less than 5.6. So if it's 5.7 to 6.4, you're called you're in the pre-diabetic range. If you're above 6.4, you're a frank diabetic. So why do I mention this? Because most pre-diabetics don't know they're pre-diabetic. Why? Because doctors don't order hemoglobin A1c. Why? Because Medicare doesn't want to pay for it. I've had many patients say, well, Medicare won't pay for my hemoglobin A1c. I have to say, what's important to you? It's Medicare would rather you become a frank diabetic, and that's also true of PPO insurance. So people that have, pre-diabetes may not even know that they're pre-diabetic, because the doctors aren't ordering A1Cs. They'll order fasting blood sugar because it's part of a comprehensive medical panel. And they probably won't order an A1C routinely unless the patient's got really high blood sugar. So keep in mind that your doctor may or may not order hemoglobin A1C. It's very important. Now, if you go to a doctor like me, an integrative cardiologist, we're going to order some advanced testing. I tend to use Cleveland Heart Lab, which is actually a part of Quest now, and also Boston Heart Lab. Those are two very good, comprehensive, advanced cardiac lab testers. And what I'm looking for, besides hemoglobin A1c, I'm looking at the fasting insulin level. Okay, that's very important. And because, again, we're concerned about hyperinsulinemia, too much insulin. So this gives me an idea of what the insulin level is. That should be fasting. The other what I'm looking for is it's called a C-peptide, which tells me how hard the pancreas is working. Now, you could have a normal A1C, okay? But if the C-peptide is high, that means your pancreas is working its butt off to keep you from becoming a frank diabetic. It's a really important measure. So I always look at C-peptides. It gives me an idea of how hard your pancreas is working. We want that to be within the normal range. If it's high, even if you're not a frank diabetic, it means you're going in that direction, and your pancreas is working overtime to avoid making you a diabetic. There's another test that becomes part of these more advanced lipid testing. It's called either HOMA-IR, which stands for Homeostatic Model of Insulin Resistance. That's what Boston does. And another one is the insulin resistance score, which is done by Cleveland. There's subtle differences between the two tests, but it doesn't matter because both tests are telling me the degree of insulin resistance that you have. So with these tests, with the simple tests that do cost a little bit of money, it's really give me an idea of how insulin resistant you are. Are you really a pre-diabetic? Or are you really edging that way to being a frank diabetic? There's even a new test out that I'm so excited to tell you about. There's a company that I've been using called Predictive Health. Now, some of you may have known I've talked about this pulse test. A lot of my patients are familiar with it. That's capital PULS. And it tests 9 different biomarkers. It tells me what's happening at the level of the blood vessels. Very early signs for heart disease before you develop calcified plaque. So now they have a new test called Diabetes Predict, and they're marketing and they're marketing this test to physicians throughout the country. But this is a collaborative from MIT, Harvard University, and also Massachusetts General Hospital. So it's well put together, and they studied lots of Hispanic population, which tends to have a high incidence of diabetes. So what this test can do, it will look at different genotypes, and I forgot how many, but it looks at whether you have a genetic predisposition for insulin production or for insulin sensitivity. So it can differentiate what kind of diabetes you might be prone to have. And it will give you a value of, okay, low risk, high risk, medium risk. Now, it's not the end all be all. It's just another genetic test, and we can't change our genes. But what it can do is to help promote prevention, help promote healthy medical practice. So, because, and this is my take home message for all of you, 30% of our outcome really is probably determined by genetics, 70% by lifestyle. And that's why these tests can be useful, because once you know your genes, you can determine, okay, this is my risk. So whether or not you do the genetic test is one thing. It's new thinking. Everybody's going to genomes now, genetic thinking and epigenetics. And we'll talk more about that in another program. But I just want you to know that there are things that you can do to find out if you are a diabetic, which most of you probably would know by now. If you're a pre-diabetic, remember 88 million people in this country are pre-diabetic, or have metabolic syndrome or metabolically unhealthy. These are really important. It's going to affect your future. So what about treatment? Okay. People have asked me for years, what is my ideal method of treating diabetes? And I've always said the same thing for at least 10 or 15 years: prevention. Prevention is the best way. This is not a disorder or a disease that can be cured. Just like hypertension, it cannot be cured. They can be controlled. And that's what our goal is. Our goal is to control them with lifestyle first and medications if we need them. Lifestyle basically is diet and exercise. That's your partner, diet and exercise. And if nothing else, it's the carbs. It's cut out the carbs. Anything white, bread, pasta, potatoes, just like that little thing that we did on my YouTube promo. Anything white is basically what you should not be eating. There's different degrees of low carb diets, and we can talk about that in the Q&A section, the ketogenic, etc. But the bottom line is decrease the carbs, decrease the snacking. I like to use intermittent fasting. I think that helps. There's different methods that we can use to improve not just what we eat, but how we eat and when we eat. And then, of course, there's exercise. Supplements. There is a room for supplements. Actually, alpha-lipoic acid improves your insulin sensitivity. I have my own product that I put together called GlucoWise Plus, GlucoWise for HeartWise, but GlucoWise Plus, and it has an herb called berberine, which some of you have probably heard of. Berberine is very good at improving insulin sensitivity. In fact, it's been shown in some head-to-head studies to be on par with metformin, which is a pharmaceutical. So it has berberine, it's got alpha-lipoic acid, it's got chromium, it's got vanadium, and it's got cinnamon. These are different ingredients that help with insulin sensitivity. And then there are drugs, which I'm not going to talk about unless somebody asks about them in the Q&A section. Drugs are secondary. Yeah, we do need them. When we need them, we use them. but there's so much we can do with prevention. So as your own medical advocate, it behooves you, all of us, to know what our risk is, to assess that risk appropriately with these specialized tests, even if Medicare or your PPO doesn't want to pay for it, and treat appropriately with lifestyle. It all begins with lifestyle. So with that in mind, we'll start off with some questions. So, okay, can you reverse diabetes? Again, it's you cannot cure diabetes. Okay, we already know that's the genetic predisposition. Once you have it, you have it. But we can definitely. My goal is always to take a diabetic and make it pre-diabetic. Take a pre-diabetic and make it into a non-diabetic. And we have that A1c goal in mind. So I work very diligently with my diabetics, and I really encourage lifestyle a lot and diet. I'm not into simply pushing pills. And by the way, on my patients that need insulin, I do send them to endocrinologists because that's a whole different ballpark. I don't want to get into insulin. It is necessary in certain patients, but it's a second stage of the disease. And there's some real drawbacks in using insulin. So I don't like to use it. And so that's when I refer out. But I'm very comfortable dealing with diabetes before that point. Okay, let's see. What needs to be done in order to make pancreas work properly? Pancreas are working hard to keep you from becoming diabetic. Lifestyle and diet. Pancreas is only going to do what you make it do. It's going to work. It's not like you can make the pancreas work more efficiently. It's your diet. If you're eating a lot of garbage and you're snacking throughout the day, your pancreas is going to have to work. Okay, anytime you have a meal, anytime. Okay, and that happens to involve any carbohydrate, which, as you know, breaks down to sugar. Your pancreas got to pump out insulin. That's its job, because the job is to take that insulin and shunt it to the liver and to the muscles for storage. We don't want it blood sugar hanging out in the bloodstream. That's one of the problems. That's the hallmark of diabetes. So the job of insulin is to shunt it, to transport it to where it should be stored. But that's a lot of work for the pancreas, and that's done repetitively by the snacking throughout the day and eating a lot of carbohydrates. It's going to have to work a lot harder. So the pancreas is made to last a lifetime, like most of your organs. Depends on how you use them or abuse them. So the important thing, diet is number one there. Okay, does hormone therapy help at all? Yes, hormone therapy does help. Good question. Thank you. Testosterone, for example, has been shown to improve insulin sensitivity in men, probably in women too. But I do use actually I use hormone. I do use testosterone in women as part of my menopausal therapy program, but it's obviously very low doses that are made for women. But yes, it improves insulin sensitivity. I'm not so, and I think there's also an improvement with female hormones as well. The bioidentical estrogen and progesterone has an effect as well. So hormonal therapy is, I think, useful once you need it. And again, that should be followed up by an anti-aging medical professional who deals with this. Yeah, there's definitely a role for that. Okay, let's see. Great questions. Give me more. Someone started off with one, but I don't have waiting for it. Let's talk a minute before I get another question. What about the role of the ketogenic diet? Okay, and that's one diet that's gotten a lot of attention lately, but it's not a new diet. It's been around since like the 20s because it was shown to be very useful in treating children with epilepsy that could not be treated with medication. Of course, medication was pretty primitive back then, but it's still useful in epilepsy. But it can be useful in those with in obesity, for sure, metabolic syndrome, for sure, diabetes, for sure, because you're drastically reducing carbohydrates to a very low level, and you're teaching your body to use fat for an energy source. There's two sources of energy: carbs and fat. Basically, carbs is a better choice. I'm sorry, fat is a better choice. You get a bigger bang for the buck, and it's actually better for the brain. And also, you teach your body to use ketones for energy versus carbs. So it's a whole process. So you want to go to someone who understands this diet, maybe a nutritional counselor. But I have seen this work on a lot of my patients with diabetes and metabolic syndrome. Your average doctor probably doesn't know much about it or won't really be in favor of it. But there's definite there's definite room for using ketogenic diet, treatment of diabetes. Also, fat is your preferred fuel for your brain, ketones actually. So your brain is 65% fat. It thrives in the presence of fat, whereas sugar actually increases the oxidative stress of the brain, which is not good. The last thing we want, dealing with a disease that is harmful to the brain, and now you have a high carb diet. There's just no room for it. Okay. Let's see. What foods would you recommend diabetics eat before and after exercise? Okay. So I used to, and I'm not a diabetic or pre-diabetic, thank goodness. And I used to always have this pre-workout meal before I worked out. And Joanne Lee from the Shrink Shop taught me many years ago that you don't really have to have a pre-workout meal. Why don't you try doing it without it? And I did. And I got rid of a few calories, started slimming down, and I found out that if I ate well the day before, I was going to have enough energy to go through my workout. Now, that's me. So it really depends on your metabolism, and I have a pretty high metabolism. So as far as diabetics are concerned, even if you're diabetic, I don't see the need to see. Diabetics have been taught to eat constantly throughout the day. Diabetic snack, and before you go to bed, and do this and do that. I mean, that wasn't even really based on real science. I don't know who made those rules up. I think it's unnecessary. I don't think whether you're a diabetic, and unless you're on insulin, okay. But if you're a non-insulin requiring diabetic, I don't see why you have to have something to eat before a workout. I really don't. I don't see the data. Okay. After exercise. Okay. After exercise, I still have the old bodybuilder mentality. So I do like to have a liquid drink after my workout. I do have carbs at that time, high glycemic carbs, and a drink with protein and some fat. I'll tell you what, but I limit the carbs to maybe like about 30 grams of carbs, 50 grams of protein and fat. Because after my workout, I want my nourishment to go to my muscles and not to my stomach. So I don't have a solid meal after I eat. I have a liquid meal, and then maybe 45 minutes or an hour later, I have something solid. That's worked for me for 20 some years. And I don't think whether you're a diabetic or have metabolic syndrome or whatever, that's going to work for most of us. Okay, Dr. White, one of the most effective nutritional supplements to modulate insulin sensitivity and control glucose levels. Well, I think I mentioned them, but here my favorites are berberine. That's really useful in improving your insulin sensitivity. Cinnamon helps. Alpha-lipoic acid helps, and chromium. These are not new supplements. They've been around for a while. I don't. There are other supplements as well. I'm not terribly exotic. I kind of stick to simplicity, and these work relatively well. I have a lot of patients I've put on my GlucoWise Plus, and we've been able to avoid medication in some of them. Now they also are looking at their diet and they're exercising. So this is for those that are compliant. But supplements can work quite well as an adjunct to lifestyle in general. Okay, Keto Bread. Okay, I haven't tried Keto Bread. I don't. I don't even eat Ezekiel bread. I really don't eat bread. It's not in my house. I mean, I may have, if I even have a sandwich, I always take a half piece bread off, and just how I am. I've just avoided bread and pasta and all that stuff that's white. So how much a day is good? Probably not the best person to ask since I don't eat it, but there's keto bread. There's gluten-free bread, and see, all this stuff is going to be processed. That's why I try to avoid as much processed food as I can. That's just me. Okay, another question. What should someone who is using insulin, even with multiple sliding scale, sugar levels are always high? Okay. So a lot of people are on sliding scale insulin because they're taught, for some other reason, they might not be able to tolerate some of the medications. For example, if you have kidney dysfunction, that disqualifies you from taking certain medications. So sometimes you have to use sliding scale insulin. I don't like it. I don't use it myself in my patients. It's usually restricted to endocrinologists. It's hard to dose. You need to have an intelligent patient who can really monitor their insulin levels. I do love the 14-day glucose monitoring systems that are out now. Abbott puts one out. And so there's like a little needle that you put in your arm here. And it lasts for 14 days, and it measures what you're eating. So let's say you had a bagel, okay? And like my blood sugar may go up to 130 after eating a bagel. Yours may go up to 180. So I really like this particular monitoring process because it tells you what foods produce a high glycemic response in you. Um, and that would be very useful for people on a sliding scale because they really have to be on top of it. Again, I think low carbohydrates would be important because whether you're on a sliding scale or not, you want to keep those carbohydrates low enough to avoid those those peaks and valleys. The last thing you want to do is to go from 60 to 300, and I've seen it before. So it's controlling when you eat and how often you eat. And again, it's the same old thing. You've got to watch the carbs. And I would think a higher fat diet would be a much better choice for people that are on a sliding scale. It's because it's more controllable. That's my feeling on that. And being seen by endocrinologist. Oh yeah, vanadium. Vanadium is also in my Glucowise Plus, by the way. I've got to mention it. It's another trace mineral. So vanadium is also useful. So vanadium, chromium, berberine is a great herb, and it's like I said, it's been shown to be effective in various studies. Cinnamon, I love cinnamon, and so those are the basic ones. I mean, I just put them all together because they work. The whole thing is you want to be insulin sensitive, and you want as opposed to the opposite, which is insulin resistance. So insulin resistance is what we want to avoid, and that's why we have this association with diabetes and cancer, and diabetes and Alzheimer's disease. It's really the hyperinsulinemia and the damage that insulin can do to the brain and to the heart muscle. So, wow. Okay, better. Okay, okay. CGM device, Dexcom or Freestyle Libre. I think the Freestyle Libre. I have not used it yet, but I'm about to start it myself. But I think most of my friends that are using this system, they like the Freestyle Libre. I don't know if there's much different. I would imagine they're somewhat similar, but I've heard some real positive things about the Freestyle Libre. The other one is Dexcom. So these are different. Doctor is asking is different systems for the continuous glucose CGM, we call it, continuous glucose monitoring, and I really think that's the key to improve not just diabetic but also blood sugar control, because it'll specify you'll get to learn what foods make your blood sugar go up. What makes yours go up may not affect me the same way, and vice versa. So it's definitely the way to go. A lot of us are using that now, and with our patients, and I think it's definitely the way to go. Great. Let's see. Let me see how I answered everything. Great questions, by the way. I think we talked about exercise. As far as what exercise, I've always asked this question. And this is going to be a future program coming up in the next few weeks. But like I would say, if you look at the research, if the literature, the medical literature, there's been a plethora of stuff on cardio aerobic exercise, and rightfully so. And I'm a cardiologist, but strength training has taken like a second seat for many, many years. Now we're getting some really good press on the benefits of strength training. For me, when it comes to aging, if I could only do one, I would do strength training. And I'm a cardiologist, but and we'll go into that later. But there's some really good data coming out. I think they both can positively affect your insulin sensitivity and improve it. So I don't care what you do as long as you do it. And I would try to get in, 5 days a week of exercise, maybe at least 2 days of strength training. Would be beneficial, but do not leave out exercise. It's very important for diabetic management and also to control your blood sugar and your insulin levels. I mean, it works hand in hand with diet. Good. I think that's about everything. And we're just about here. We're 7:34, and I started a couple minutes late. Sorry. Well, great. I thank you guys. Thank you so much. Let me see. Oh, wait a minute. There's one more question. I'm not gonna leave it out. I have to wear my glasses because senior moment is pretty so small. If pulse score is high, is exercise good? Absolutely, absolutely. Because with the pulse score, and we'll talk about that in detail. The pulse score is telling me what's happening at the level of the endothelium. So the endothelium is one cell thick, and it lines all of your blood vessels. Okay, for your big arteries, your medium-sized arteries, your small arteries, even your capillaries. As long as that endothelium is intact, I don't care what your cholesterol level is, nothing's going to happen. But through things like age, stress, lack of sleep, smoking, high blood pressure, high homocysteine, and other factors, the endothelium gets disrupted. And that sets the stage for inflammation because LDL that's oxidized can get in there and start forming plaque. And then smooth muscle cells get into the area to try to contain it. And finally, calcium is the last thing that ends up in plaque. So, you can I've had many patients with 0 calcium scores with high pulse tests. So, and I tell them, and I probably was one of those, because when I had a negative calcium score, within a year, I had a minor heart attack. And no risk factors at all. But who knows? They didn't do pulse testing back then. I had something going on in my endothelium. So it tells me what's happening at that level, which is really useful, because exercise clearly improves the integrity of the endothelium, along with supplements that I'm using now and a healthy lifestyle. So yes, it's very good. Okay, here you go. I recently had to be hospitalized because of low blood sugar. I was checking my levels and yet ended up in trouble. Okay, I know this particular person. Here's a problem: is that this is a problem with sliding scales. Is that you can undershoot and overshoot, and if you overshoot, you can become profoundly hypoglycemic, which is actually that could be life threatening. There have been people that have had heart attacks and strokes because they got so severely hypoglycemic, and they can become comatose as well. So that's why I'm really careful. I don't like sliding scales. I leave them up to an endocrinologist. I don't feel comfortable as a cardiologist using them because I have to almost be on top of the patient. But I do think using the continuous glucose monitoring will help, and checking it frequently after everything you eat. Everything you eat, all you can just put your phone right next to the monitor, and you've got a reading, and that way you can stay ahead of the game. It's all about staying ahead of the game, whether it's glucose or anything that we do in functional medicine and preventative health. So, can it be prevented? You really have to learn your body. Okay, that's also a big proponent of being your own medical advocate, is knowing your body. Once you use this continuous glucose monitor, you'll know what foods affect you. What foods will make your blood sugar really rise. You don't want to be like the cat chasing the tail. That's the problem with sliding scales. Oh, my blood sugar is high, so then I give myself glucose with the sliding scale. Then I overshoot by accident, and I end up in the freaking hospital. Not a good way to go. So it's about, you need to be taking notes. You need to be writing things down, if that's what you have to do to avoid hospitalizations. All right, great questions. Thank you, guys. Thank you so much. Thank you for coming tonight. We'll see you 2 weeks, I believe, is Thanksgiving. So we'll make it 3 weeks. And I don't know what the topic is yet, but I'll figure out something cool. Okay, thank you. Good night, everybody. Thank you so much. Okay.